Good evening. Hello. Nice to see everybody. We are live coast to coast, CNY Nation, and internationally, in fact, via internet. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado. I'm also the medical director of the Miami Center of Excellence and CNY Fertility's Monitoring Center in Miami, Florida. So if you're in Miami, join us over there. And if you're joining us on the internet this afternoon, it's so nice to see everybody. I've got, we've got Facebook and YouTube and LinkedIn right here on this camera. And we've got two separate Instagram feeds here. So if you see me sort of bopping back and forth, that's because we're trying to look at everybody. Gosh, everybody's joining in, and it's so good to see people here. Felicia has your first beta tomorrow. Oh, we are with you, sister. Glad everybody's with me here today. Fertility with Fink and Friends. It's been mighty chilly here in Colorado Springs. I will tell you, we've had some really cold days. I think it was 1 degree when I got here to work yesterday. But if you know anything about Colorado Springs, I think it's supposed to be 50 degrees tomorrow afternoon. So there is no rest for the winter weary. Just want to give a couple of shout outs and say hello to, I wish I could say hello to everybody. Hi, Kelly Presser. Say hello to everybody. And hey, Staley. Staley is with me in Miami. So is Lauren Oliver Green, my dear friend, and her beautiful husband. Want to say hi to, of course, my friend Amber Vince, who is in Kentucky, and hi, Caitlin. Hi, Allison. Gosh, hi, everybody. You know, we've had some really interesting things happen this week, and we're going to talk about a bunch of things here. All your questions, Fertility with Fink and Friends, please feel free to ask them. I'm going to try to get to everything we can. I've got a special guest who's going to be joining me in just a couple of minutes here. But if you've been kind enough to follow my Instagram at all, and that's Randy Fink MD. If you haven't, please do. I try to come up with some witty, amusing things that are both educational and kind of hopefully make you laugh, make you smile, make you think. I did a kind of a funny video that I ended up putting on TikTok, which, be honest, I have not been a social media person for a very long time. And I put that funny video on TikTok, and within like 2 or 3 days, it had about 7,000 views. So I don't really know what to make of that. But if you don't watch me on Instagram, please do, Randy Fink MD. And I asked a question earlier in the week, and that was, if there was one thing that you could tell your fertility specialist that, or even your OBGYN, that you haven't yet, if there was one thing that you could say or ask, what would it be? And Alyssa Marie responded very wittily so. Why does progesterone in oil have to suck so bad? And I think that's a brilliant question. And progesterone in oil, if you haven't had the delight in the experience of it, is the injection of progesterone that you get after you have had in vitro fertilization. And so the 900-pound gorilla in the room is that it goes into your butt. Well, it doesn't actually go into your butt. It's an injection that is a gluteal injection. So it goes into the muscle of the butt. It's a thick injection. It doesn't feel good. First question is, why does it have to be injected into your butt? Why does anybody need to get butt injections? Because they're pretty unpleasant. Most people don't like showing other people their butts and don't want to have to get a needle in it. It's a big muscle back there. It's a big muscle, and it's a big vascular muscle, and it's able to absorb whatever you're putting into it very freely, very easily. And when you put that kind of material, that thick material, into the muscle where it's going to be absorbed through the blood supply, it's good to have a big muscle to do that in, because let's say you were to put it in your arm. So this is what's called the deltoid muscle here. If you put that into the deltoid, it's a very small muscle. And so that kind of volume, that thickness would really be unpleasant, even more so unpleasant than it is when it goes into the glutes. So why do we have to use progesterone in oil anyway? Why can't you just use vaginal progesterone? So, and I see all kinds of hi to everybody who's joining. Thanks so much for being here. We're going to get to trying to get to all your questions, but I do just want to mention this because I think it's important. Why do we have to use intramuscular or injectable progesterone to begin with? Well, the reason is in nature. If you were to get pregnant in nature, your ovary releases an egg. And when that egg gets released, your body starts making progesterone. The space where that egg came from turns into a little progesterone factory, and that's what's called the corpus luteum. If you've heard that term, the corpus luteum makes your progesterone, and that progesterone is designed to support your pregnancy until about 9 weeks of gestation, which is when the placenta takes over and starts making progesterone. Well, you need extra progesterone when you've done IVF because your body isn't making it, right? We haven't let your body release the egg. You haven't made an egg to be released. We've retrieved it. And perhaps you're coming back for a frozen embryo transfer cycle. Well, we've actually, in most cases, suppressed your ovulation. So you're not making your own progesterone. We have to give you extra progesterone. Some people say, I don't want to use that shot. Like Alyssa said, the shot sucks, right? So why do I have to use the shot if I'm using vaginal progesterone anyway? Well, the vaginal progesterone has a local effect inside the uterus. And so it is able to talk to the cells inside the uterine lining and tell them what to do. But you still need some more. You need that systemic progesterone, and that's what the shot does. The data shows us that when we use progesterone in oil, the injection, our outcomes are better than when we use vaginal progesterone only. And since ultimately our goal is to get you pregnant, we use progesterone in oil. If you absolutely can't tolerate it, you can use progesterone or vaginal progesterone only, but just understand that the outcomes are not as good. Some people do ask about, well, is there anything I can do that makes giving it, I can't get used to doing these shots. And I'm sure, many of you have been through that, or you have friends or folks who are going through the process who feel like, they're petrified, they're terrified of the needles. What can you do if you don't like needles? I don't really know anyone who really likes needles. So, sometimes we'll see people who have a tremendous number of tattoos. And many of those people don't like to get a shot or have a blood draw, but they've gone through unbelievable things to get body art. So what can you do if you don't like to give yourself the shots? Get a friend. Almost everyone has a friend who is involved in medicine, maybe a nurse, a medical assistant, a friend who is an EMT. Some people will go to their local health clinic or to their own OBGYN's office to get some help with getting the injections. And in many cases, I've heard folks even going to the fire department and letting the fireman help to give the shots. So as you know, many of the shots that are subcutaneous and just go into the fat are like little sort of insulin needles. They're very small needles. Those are much easier to use than an intramuscular injection, but help is available. If you're not sure, let us know. We can try to guide you, or ask outside in this really wonderful community of folks who are going through the same process who may be able to give you some advice. And I will say again, that's one of the things that I really love most about CNY Fertility, in addition to having the pricing structure that we do to be able to make having a family available to everyone, not just wealthy people. It's that there is such a wonderful community of people who are always willing to reach out, always willing to help other people who are going through the process. So thanks to all of you who are joining me here today. I'm going to ask a very special guest to step in with me here. Would you please allow me to welcome my friend and colleague? This is Kayla Dionese. Kayla is our she's much better if we just put this in front of your face. Exactly. So that, Kayla is our nursing director of the operating room here at CNY Fertility, Colorado. So she can also answer some questions about what the experience is like when you come for a retrieval or a transfer, what some of the nursing aspects are, what happens after you get your phone call. She is one of the lucky people who are able to give you your FERT call, the fertilization call, after you've done an IVF retrieval. I'm going to move this over here so we can just see a little bit better. So Kayla is a wealth of knowledge, and if you didn't notice, she has been in a couple of my videos because she's also quite a character. She did the squirrels in my pants video. If you have seen that on Instagram, I saw somebody said a little earlier that you like the squirrels in the pants video. That's all her. And she did my IVF retrieval video just yesterday. We put one up just to kind of show again. Our colleague Brandis, our wonderful nurse practitioner here in Colorado Springs, made a great video for the CNY website, or rather for the CNY Instagram, that was sort of behind the scenes at your embryo transfer. And so that's still available there. And look here, Erin says you were her nurse for the retrieval and she loves you. Obviously you don't know her. So I would just say, get to know her before you say that sort of thing. Right? Yeah.
Hi, Erin.
Ariel on the Facebook side is asking about how about metformin if someone doesn't have PCOS or isn't insulin resistant? You know, that's a great question. Metformin also helps with egg quality. So most of us have some degree of insulin resistance, and you know, we could argue that oh, look here, and you called Kelly with her FERT report. Kelly, did you have to curse at her, or was she was okay? No cursing? Did you curse at Kelly?
No, I would never do such a thing.
So, all right, fair enough. Metformin helps with egg quality. So we put a lot of folks on metformin with diminished ovarian reserve, even people who do not have overt polycystic ovarian syndrome. But of course, it affects insulin resistance, which is a major feature with PCOS or with people who have ovaries that behave like PCOS. So in folks with PCOS, metformin does also decrease the miscarriage rate when continued through about 12 weeks of gestation. But specifically, Ariel, there about metformin without known insulin resistance or PCOS, we think of it for improving egg quality. Great question. Thank you. Thanks so much for asking. And I do want to say here, Ariel had a little follow-up, and that's that the nurse is told to stay on low-dose naltrexone until the next IVF. Well, low-dose naltrexone is one of those things that is very popular in the anti-aging world. It is a very common immune modulator. There are some people who go on low-dose naltrexone and they stay on it for years at a time. And if you look on the internet, you'll see that folks say that when they're on low-dose naltrexone for a prolonged period, you never get a cold. You just don't get many of the viral infections that maybe your young kids may bring home or that we get from just being out in public. It's really a wonderful immune modulator. And because it increases endorphins, it has an effect on blood flow and hormone receptivity. So staying on it probably just helps you. We take it at night when we go to bed because some people do have peculiar dreams on it. If you're tolerating it and you're doing okay with it, I do recommend that you stay on your low-dose naltrexone. So good question there. And so Carly says, hi, Kayla.
Carly.
Gosh, man.
Kelly, I just saw your FERT report you messaged in. Congratulations. It's hard for me to remember everybody, but.
Retrieved 30, 21 mature, and 20 fertilized. And you got 16 blasts. Holy cow. That is What a gift there, Kelly. I'm so glad to hear that. Let's see on the CNY side. I saw there was a question back here. Just found out that the fertility issues are because of spouse. This comes from love for Kashi, I believe that says. This is really a question about male factor infertility. What can we do for male factor infertility? And it's a common thing where folks will believe that women will believe that, well, if there's a problem getting pregnant, it must be because of me. Obviously, I'm the one who has the baby, so there must be some problem with getting pregnant. And the truth there is that in at least 40% of the cases, there's a male factor. We can tell that pretty easily by doing a semen analysis, which will show us how many sperm, where the sperm are swimming, that they're going in the right direction. We collect, so folks can collect semen at home, do a sperm test at home and ship it to us. They can do it at a local clinic and have those results sent to us. They can also come here and do it right in our clinic if you're local. There are some things that can be done for male factor. There are some fertility vitamins, not a lot of great data on that. When men have a low sperm count, sometimes we can use clomiphene citrate or Clomid, which will help boost a sperm count. We can also remember that if, let's say that there's an issue with a sperm count. So a normal sperm count is going to be anything above about 15 million. All right, anything above 15 million. And let's say that your partner has 2 million sperm in the semen analysis. Well, that's functional male infertility, and it's going to be difficult for you to conceive naturally. Not that it can't happen, but it's going to be difficult. As far as IVF goes, how many sperm does it take to fertilize an egg?
One.
It takes one sperm to fertilize an egg. So if you only have 2 million sperm, that leaves about 1,999,999 more than we need for that one egg. So in IVF terms, a sperm count issue is something that's very easy typically for us to overcome. Jazz Reed says, oh, you got the news of a 1M baby and you're transferring this month. We will look forward to seeing you here for your transfer. Kayla, tell us how the situation works. That so someone comes in, they have a retrieval. The eggs go to the lab and then they try to fertilize them, right?
That is correct.
Okay, so then the next day, because it takes 24 hours for us to look at those to make sure that they fertilize, you call people, and what's the conversation that you have?
So embryology first communicates with us, and they give us 3 numbers that we look at. And the first number, so when we call you, first, it's our priority to check in with you to see how you're doing after retrieval. And then we go ahead and go over, remind you of the egg count in total that was retrieved on your day of retrieval. And then we go over how many of those eggs were mature, because it's the mature eggs that can be fertilized with sperm. So then we give you that second number, which is the mature eggs that were injected. And then our final number that we give you guys is the embryos that you have that day that you can potentially transfer if you're doing a fresh transfer, frozen transfer, or if you're deciding to do genetic testing. So that's kind of how that call goes. And then we get you all scheduled for based off of your plan. We either get you scheduled for your fresh transfer if you're doing a day 3, or pushing those embryos out to blastocyst, doing a day 5 transfer. And then kind of talk you through when to expect what we call a cryo report, and that comes from embryology, and that's typically uploaded to your portal in about 8 days. And that's pretty much what's involved with the fertilization report. Answer any questions you might have, and then obviously communicate any updates with embryology that you may have to your plan moving forward.
Awesome. I want to address something here on the CNY Instagram side that came from Rachel Christina, who I'm very sorry to say just lost the first FET baby due to a large subchorionic hemorrhage. So let's talk about that. Well, are the odds of a second FET still good? My answer to that is yes, absolutely, because what we learned the first time was that the hormones know how to talk to the uterus knows how to listen, the uterus knows how to implant that pregnancy. The subchorionic hemorrhage is something that can happen in any pregnancy. I've had this conversation several times today. The miscarriage that occurs after IVF is almost it's cruel and unusual punishment because a miscarriage is bad enough in a naturally conceived pregnancy because it's a member of the family. It's really truly a loss of a member of the family. But in IVF, after having gone through everything that you have in order to get that pregnancy and to see that heartbeat and then to lose that pregnancy is almost just cruel. So our hearts go out to you there, and I'm so sorry to hear that. Let's talk about what a subchorionic hemorrhage is. And to do this, I'm going to ask for Kayla to help me with a little visual. Go like this. Okay, let's make sure that
I'm in
everybody
frame
can hear. Yeah. Okay, so let's see. Actually, stand up.
Okay.
Okay, wait, now actually sit down. No, now stand up. All right, all the guys like that. All right. Okay, so let's say, and everybody can see on all the screens here. All right, so let's say this is your uterus, okay? And here is the cervix. The cervix is going to do 2 or 3 processes once it's time to have the baby. The cervix is going to thin out. It's going to start to what's called efface. So the effacement is when it gets thinner. It's going to receive the contractions of the uterine muscle here, and it's going to start to dilate so that the baby can come out, right? In the first trimester, the cervix is closed, and let's say that the baby has implanted here, right? Well, as you know, the uterus gets bigger and bigger and bigger. The uterus is going to grow with your pregnancy. And it's amazing that we could deliver you or do a C-section and see a uterus that is literally the size of a watermelon with sometimes a 10-pound baby that just came out of it. And 6 weeks later, you come back for your postpartum visit and your uterus is back to the size of a lemon. It's really a very impressive organ. But let's say the pregnancy implants right here. Well, as the uterus grows, what's going to happen to that placenta? Sometimes the placenta can implant over the cervix, and that's something that later on in pregnancy is called a placenta previa. And in many cases, that previa will resolve as the uterus grows, or it can maybe a low-lying placenta. It's close to the cervix, but in any event, it's here the uterus grows, and as the uterus grows, the placenta starts to move with it. And sometimes as that placenta starts to move, it can shear off a little space underneath and create a bruise. What's a bruise? If I punch myself in the leg and you look at it, it turns all black and blue, right? It's a collection of blood that's under the skin. That bruise that's under the placenta is called a subchorionic hemorrhage. Now, most of that blood is going to get resorbed into the system, but some of it is going to come out the door because it's just a close exit. That's the most common reason that pregnancies will bleed during the first trimester, because the placenta is moving as the uterus is growing, shears off a little space, and that blood comes out. Now, if that little bruise, and it's very common, this can actually, some studies show that subchorionic hemorrhage happens in up to 85% of pregnancies. So 1 out of every 2 pregnancies in the first trimester will have some vaginal bleeding. And that's really the reason why. In our world, in IVF, the progesterone that we're putting in, which the lining needs, can also sometimes contribute to that bleeding there. So, If that little bruise, however, continues to grow and get bigger, then it can separate the uterus from the pregnancy, and then there's no blood flow that's going to the pregnancy, and the pregnancy will end. So thank you. Nice.
You're very
I see
welcome.
that our friend Jody says nice uterus.
Oh, thank you so much.
That's the reason that people will bleed. I will tell you that first trimester bleeding is one of the scariest things that will happen to you if you're pregnant, because from the time you get that positive pregnancy test, and any of you who have been pregnant before can attest to this, it's a roller coaster that you can't control. It's something that becomes everything that happens to you, you worry about, you wonder about, is this normal? Is this going to be okay? What's happening to my baby inside? And so to see some blood coming out can really be a frightening thing. So again, our hearts go out to you, Rachel. I'm so sorry that happened, but we have such high hopes for you in the future there. So thanks again to everybody who's joining us here. It's about 27 minutes after the hour. This is Fertility with Fink and Friends, live from Colorado Springs. How many months does it take for a successful IVF? It looks like Samran is asking. Forgive me for that pronunciation. How many months does it take? Well, the IVF process at CNY is that once you've had your consult with us, our team, the global, if you don't live locally, if you live in one of our, the vicinity of one of our local facilities, which would be Colorado Springs, Syracuse, Buffalo, or Albany. Then we have some ancillary centers also in Sarasota, which is awaiting to open to do full service IVF, but they're open now with monitoring and IUIs, and in Atlanta as well for monitoring. Either one of our local nurses, if you're local, or part of our global travel nursing team will reach out to you, and they typically do a phone call 2 to 3 weeks after our initial consultation, go through the logistics of the process with you, make sure the medications are in your hands, and then basically we wait for you to get your period. And that's the trigger to start the process. The stimulation portion lasts for 6 to 10 days in most people. And then we give you a trigger shot, which the stimulation portion gets you to make as many eggs as we can get from your ovaries. The trigger shot tells the ovaries, hey, we're coming for you. It allows you to get ready to release the egg, but not to let it go, because we want to retrieve that when we do our egg retrieval under some anesthesia. So the entire process of stimulation to trigger to retrieval in most patients is about 14 days. So if you haven't started yet and you're wondering about that, that's a nice way to kind of think about it as one half of a menstrual cycle, typically about 14 days. When we do retrievals here, what do you think is the number one thing in your experience for our patients in the operating room? What's the number one thing they worry about?
I believe in my experience, the number one thing most women worry about coming in to do their retrievals is, am I going to get any eggs? Or a lot of times I get, what's a good number of eggs for me to get? So I think the biggest worry is maybe that they've already ovulated or they're not going to get any eggs at all.
So really it's a worry about what's going to happen. Is this going to work? It's a worry about the unknown, would you say?
Yep, absolutely.
Do you think is it more a worry about the unknown than it is a worry about the actual process of being here?
I think there's a mixture of both. Essentially, I think when people come in there and they haven't maybe done a retrieval before, they have some nerves about the whole procedure itself. Going under anesthesia, being asleep for the procedure, how am I going to feel afterward? I already feel kind of like I'm bloated and crampy prior to. What's the recovery process like? But there is that number one thing that I think most people coming in to do IVF is, am I actually going to have eggs to hopefully eventually get a transfer with?
And I think that's a reasonable question. The ideal number of eggs, people ask me that all the time. What's the ideal? How many eggs should I have? Well, what the data on that shows us is that anything more than 15 eggs does not improve the outcomes. So 15 is a great number. If you have less than that, guess how many it takes to get the job done? It takes one good egg and one good sperm. And so that's really kind of what we're looking for. Hi. Asks about women over 40. Do we have success stories? And the answer to that is yes, every single day of the week. Now, by the time we start to get to be about 45, the odds of success with IVF certainly go way down, but it doesn't mean that it can't happen. In fact, at 45, the odds in general are very low, and there are many clinics in this country, IVF facilities, who will not even allow you to do IVF because they're concerned about their outcomes and what they are going to report. They're trying to artificially perhaps elevate their numbers, their success rates by sort of cherry picking the patients who they will allow to do treatments. And so they will exclude you if your ovarian reserve hormone, the AMH, is below a certain number, or if your age is above a certain number. But every day of the week, folks over 40 get pregnant here. We do anywhere from 12 to 20,000 cycles a year at CNY Fertility, and so the success stories just keep coming. Jen asks a question here on the Facebook side. Dr. V in Atlanta has suggested PRP before another transfer. Is there a conflict between PRP and an intralipid infusion? The answer to that is no. And let's talk about those two things. If you're not familiar with PRP, we draw a tube of blood. Where's the best place you find to draw blood from?
For PRP? Right in the big vessel in the arm, the AC.
So it's easy to get to that nice big vessel there. We get a nice big juicy vein. We take a tube of your blood. We're able to separate out the portion of your blood that has what we call your tissue factors. That's your healing factors, your growth factors. And in order to be able to use that tissue for something else in you. We use PRP a lot in aesthetic medicine. We use it in facial injections. We use it to help regrow hair that's lost. It can be injected into joints, sick joints, and many, many uses for PRP. In our world of fertility, we can place PRP directly into an ovary for someone who has a diminished ovarian reserve, and it may have the ability to improve the blood flow, the blood vessels, the blood flow that's going to the ovaries, and can improve outcomes. That's something that's considered experimental, but we do intra-ovarian PRP injections in our facilities really every single day. We can also do an intrauterine PRP wash. So since PRP is the healing portion of the blood, when we place it inside the uterus, it's probably one of the most soothing salves, if you will, that your body can imagine. So particularly for folks who have had pregnancy loss before, this is a great treatment. Intralipid is part of our immune protocol. Where do we go here? There we go. Intralipid is part of our immune protocol, and it's basically like, it looks like a milkshake, but it's a fat infusion. It's basically like an IV version of the keto diet. It's like getting IV keto. And why is Dr. Kiltz so adamant about keto? Because it is anti-inflammatory. So getting that dose of natural fat is very anti-inflammatory in the body. And we know that inflammation plays an important role in keeping people from getting pregnant. So Tiffany says, great video. Well, I guess you're saying it was a great video or I'm a great video doctor. I'm not sure, but whichever one, Tiffany, thank you. I appreciate that. Let's see what else we have here. Some other questions. Ask them. Well, looks like we can probably try to get to everything we have here. It's 37 minutes past the hour, 4 o'clock here in Mountain Time. Looks like Pretty Mamie is doing IVF after a tubal reversal 9 years ago. A fresh or a frozen transfer? Always a big question that people have for us, isn't it?
Yes, all the time.
So there are differing opinions on this. In general, a frozen transfer will have a higher success rate than a fresh transfer. Now, at CNY, fresh transfer is included in the price. So if you can do it, you have enough embryos, by all means do it, because you may just get pregnant and it's going to save you some time and save you some money. There are some circumstances where a fresh transfer may not be a good idea. So if the body becomes hyper stimulated, as I always say, your body paid a little too close attention to the medications and really made you a lot of eggs. That can be a good thing. You have a lot of eggs, but quantity is not always as good as quality. And I saw a little earlier, someone I meant to mention about it, and I forget where it came from here, that she has PCOS. She got a little OHSS, a little ovarian hyperstimulation, and didn't get a great fertilization rate. And that's because quantity doesn't equal quality. I would much rather give you a lower dose in that scenario, make fewer eggs, but a better quality egg. So fresh or frozen, if you're hyperstimulated, fresh, not a good idea. There are times that folks get really upset with us here when we tell them that we think that they should not be doing a fresh transfer. It really depends. And also, there's some pretty good data that shows us in women who are over 40 that the pregnancy rate is significantly higher when we do a frozen transfer compared to a fresh. So great question there. Appreciate that. Kellyanne Diaz says, can you transfer more than one embryo if they are all low grade? So the grade of the embryo is a really common question, isn't it?
All the time, every transfer almost.
Yep.
Yeah.
So what do you tell folks? That it doesn't matter?
Actually, no, because it does matter. Day of transfer, they're going to talk with our providers who's doing the transfer, but it can put a higher risk to your pregnancy if you are transferring more than one embryo.
Yes, agreed. As far as embryo grade goes, the embryo grading, as we always are fond of saying, is a beauty contest, right? It is a way of the embryologist looking at the embryos and trying to describe what they see. And this description was originally created so that they could try to determine can you tell from looking at an embryo whether it's going to be a chromosomally normal embryo? And the answer to that is no. The answer to that is no. You cannot tell from looking. So you can have a very highly graded embryo, which can have a complex chromosomal abnormality, or you can have a very poorly graded embryo that's the only normal one in the bunch. So don't lean too much on grade. Our embryologist will help you to select what is the prettiest embryo for transfer. They have to have some reason for picking an embryo. So usually we pick the highest graded embryo. But aside from that, it shouldn't really make too much difference. As far as transferring more than one, there are guidelines from the American Society for Reproductive Medicine, or the ASRM. The guidelines are that depending really on on your age, on where the embryos come from, if they're from a donor egg or they're yours? Are they day 3 or are they blastocyst embryo? There's some specific recommendations. We don't want you to have multiples. There are people who come to us every day who say, well, I just really want twins or triplets. We don't want that to happen. That's not what we want for you, because while putting back more than one embryo may increase the probability of getting a positive pregnancy test, it probably does not increase the birth rate. In fact, what happens is that it increases the complication rate and potentially even the pregnancy loss rate. So when folks want to put back more than one embryo, we're usually very cautious about telling them that's a recommendation, and really want to review that sort of very carefully. Do the odds increase for a second IVF pregnancy after a first IVF live birth? Yes, it does. Once you've had a live birth as a result from IVF, statistically, you have a higher chance of being successful in another IVF cycle. Let's see. Kelly asks about PRP versus an HCG wash. They are not exclusive. In fact, we usually recommend, as part of our immune protocol level 3, we recommend both an HCG wash and a PRP wash. And they can be done together. So they can mix the HCG with the PRP and put that teaspoon of fluid both in at the same time so that you don't have to undergo 2 different procedures. Laura, we're so happy to see you. She's going to be here for an IVF. Not sure when you're coming, but we will wait for you right here. Oh, and Scott, you have an appointment on the 27th. I just saw it there. Thanks, Laura. Looking forward to seeing you. Let's see, Caitlin here. Let's show this question. It's a good one. I'm 27 and I have hypothyroidism and polycystic ovarian syndrome. Caitlin's menses are sporadic and irregular, 2 or 3 cycles a year. Infertility's been going on for some time now, about 7 years. Some studies show us that the average woman will suffer with fertility concerns for 5 years before they will mention it to their provider. So glad you're here, Caitlin. I'm worried that my body will not ovulate or produce eggs. So the biggest thing about polycystic ovarian syndrome is what we call chronic anovulation. Ovulation is when you release the egg, and ovulation is when you don't, right? So PCOS, if you're having cycles that are only 2 or 3 times a year, it's probably that you're not ovulating. Fortunately, that's generally a pretty straightforward process for us to overcome. So even your general OBGYN doctor can probably give you some medication that will help you to ovulate, that may just help you to get pregnant on your own at home without having to undergo treatments. So thanks for that question, Caitlin. And I know that's something that we can help you with. There is definitely hope for you in the future. T-Bird asks about a failed fresh transfer. Which doctor looks at the plan for the frozen transfer? Well, that's something that you can ask of the folks who are taking care of you. If you're cared for by the global team, you can talk about a medicated frozen embryo transfer, or what we call a modified natural frozen embryo transfer. This is also something that folks are asking us about when they even come in for their retrievals. Yeah.
Yes.
Many questions about it. There's a lot of confusion about it. The internet, I don't think, is. What's your opinion about the internet as far as fertility information, since you get to handle it on a frontline basis?
I would just recommend not trusting everything you hear or see on the internet. Go to the people like Dr. Fink who have done this for several years and who are the true professionals at what they do. So that would be my recommendation. Internet
is the world's biggest bathroom wall. So, you can read anything you want in the bathroom wall. It doesn't necessarily mean it's true. If you're cared for by one of our local teams of nurses, either in Colorado or in one of the New York locations, in Atlanta or in Sarasota, the team will be able to look at your protocol for you and make some recommendations. If you would like to talk to one of our providers, we are always available for you to look at those things, to look at your protocol, to look at the immune protocol. While we're here, let's just talk briefly about that medicated cycle versus a modified natural cycle. So in a medicated cycles have been around since IVF was invented, right? So for decades, people have been doing these medicated cycles, and that is you get your period, or maybe you don't. We give you a period, and then you start with some estrogen. 6 to 8 days of estrogen builds up your lining. Then you get another ultrasound that shows that your lining is thick enough, after which you get 6.5 days of progesterone, and then you get a transfer. That's a medicated cycle. That's the cake. Anything we put on the cake is just icing. That's the immune protocols. The cake is the same every time with a medicated cycle. And the argument for that was that, well, there's nothing that's natural about IVF, right? So if nothing's natural, why would we want to do anything natural? We want to be able to control every avenue, every aspect, every nuance of that cycle. And that's what the medicated cycle is for. But the natural cycle is where, like what might happen in nature. So in a normal menstrual cycle, your ovary develops an egg, right? That egg grows and gets bigger and bigger and bigger. The cells that are surrounding that egg, as we've talked about before, those are called granulosa cells. The granulosa cells make your estrogen. That's where your estrogen comes from. So that estrogen naturally will build your lining. Then once we see that the lining is, once we see that the lining is thick enough and that the egg or the follicle in the ovary is mature, we can trigger your ovulation. We give you an injection of medication that causes you to release the egg. Once the egg leaves the ovary, that space, which we called before a corpus luteum. See, she was paying attention. I wasn't sure. I wasn't sure that I was going to get an answer from her, but we did. That corpus luteum it turns into the progesterone factory. And that progesterone that your body is making seems to be the magic sauce, because the modified natural cycle has a little higher pregnancy rate. It has a little lower miscarriage rate, and it has a lower risk of certain types of pregnancy complications later on, specifically blood pressure related complications once you are pregnant. So I am a big fan of that modified natural cycle. It has some potential pitfalls. So if you're doing a completely natural cycle where we're not going to trigger your ovulation, well, then your ovary is going to release the egg when it's ready to, right? And the problem with that is that may mean that your transfer is going to take place on a Sunday. And what happens to CNY Fertility on a Sunday?
We shut down for the day.
We are not open, right? And so none of our locations are. And if that happens, then you don't get your transfer that month. We have some control over it if we can trigger the ovulation when we see that the egg is mature. So we make sure that you do get your transfer. So if you talk to me, there are some circumstances where I will say, absolutely, let's do the medicated cycle. But I sure do like the modified natural. So feel free to ask your provider about it, or if you're talking to the nursing team, they're well versed in it and can help you there. Sarah over here on Instagram. Hey, Sarah, glad you're here. Sarah has a luteal phase defect. The luteal phase is typically only 5 to 7 days long. What is a luteal phase defect? We talked about that thing that happens in the ovary when the egg gets released called a...
When the egg gets released? Ovulation.
And what's this thing that's left behind?
Oh, corpus luteum.
She did it again. See there? The corpus luteum makes progesterone. In most people, the first half of the menstrual cycle can be quite variable. In people with a 28-day cycle, typically it's going to take 14 days for you to get that egg to the point where it's ready to ovulate. It gets released, and then the luteal phase is almost always 2 weeks. So there can be variability in the beginning of the cycle. If your cycle is longer or shorter, it's usually because the first portion of the menstrual cycle, which we call the follicular phase, is longer or shorter, that your ovary takes either a little more time or a little less time to make the egg to be released. And then you have your 14-day period, your 2 weeks of when you're in the luteal phase. Well, in a luteal phase defect, the problem is that it's the second half of the cycle that gets altered. And when that happens, the way the progesterone talks to the lining of the uterus can change. So your question is, will that be an issue doing IVF? And the answer is no. The answer is no. That's right. Thank you. She's very good. She's good. The answer is no, because we are going to control all those things. So that's one good reason why we would do a medicated cycle rather than a natural cycle, I believe. Even though we do that modified natural cycle, we are still giving you extra progesterone, both vaginal progesterone and progesterone in oil. So we could control for that, but in someone who really has a notably short luteal phase, I believe a medicated cycle allows us to control all those variables a little bit more, and it will not be an issue for you, Sarah. So one less thing to have to worry about. What do you say? Jen says she'll see us soon. Looking forward to seeing you. Veronica over here on the Facebook side, currently pregnant. Thanks to us. Thank you, Veronica. God, what a wonderful, wonderful. We live to hear those things. You have one last embryo and you'd like to do a natural FET. So how long after giving birth can you do an embryo transfer? And does breastfeeding affect your chances of implantation? The answer to that is yes. So what I was going to say is we recommend that you not be breastfeeding when you do an embryo transfer cycle or even when you do IVF. The hormone that causes lactation is called, you know what it is? Prolactin. It is. That's right. See, God, she's on fire, this one here. Prolactin causes lactation in the breast, and the prolactin hormone can interfere with the other hormones and the way that you're going to create an egg. We recommend that you not be breastfeeding, and generally the recommendation is 6 months after having a baby in order to go back and do some IVF treatment. Although some people will say 3 months, I think it is probably an individualized choice, and we'll be happy to talk to you on that. But if you ask me globally, I would tell people give it 6 months, get a chance to get to know your baby. And one of the reasons for that is again, the reason that we don't like to transfer multiple embryos is because of the risks for preterm labor. With multiple pregnancy, the risk for preterm labor goes significantly higher. Probably the only preventable risk factor for severe preterm birth, the only thing that we know that we can do to stop an extreme preterm birth is not to have a short interconceptual interval. Meaning to say, if you have what they call Irish twins, people think, isn't that so cute? She got pregnant again right away after having the baby. Well, maybe it's cute. Maybe you can make hand-me-downs of clothing, baby clothes easier, and it's easier to push them around in a stroller when they're born. That's the one preventable risk factor for severe preterm birth. So we really don't want you to have to go there. And that's the reason kind of for the delay. Kayla, what's your background? How did you come to this IVF world?
Oh, background. So I graduated nursing school back in, feels ancient for me, 2012. So I've been a nurse for well over 10 years. I started in cardiac and spent about 7 to 8 years in the ICU. I decided I wanted to travel for a year. And then I was missing home, which Colorado is my home. I came back, and at that time I had spent 10 long years at the bedside, and I just wanted a different avenue. And I just, this CNY kind of just fell into my lap. I knew some of the girls that were interested and working for CNY through mutual people, and I actually one of my best friends talked to me and said, you know what, Kayla, why don't you give Fertility a chance? I've went to the facility and I've heard nothing but good things, and maybe it's time to, pursue something different in your nursing career. And I applied while I was still out in Texas, and I ended up getting the position here at CNY, and it's been a blessing. So.
I do want to say Kayla is one of those heroes who was working, toiling endlessly in the ICU in the peak of COVID. And so that in many ways is having gone to war. And so we appreciate all you do around here for us, your friends and colleagues at work, for our patients here, but certainly for what you've done for all those families out there who have suffered so much with COVID. And so glad hopefully these days are turning different now, and we can look forward to some better things. Well, folks, we're going to get close to wrapping it up here. Fertility with Fink and Friends from CNY Fertility in Colorado. It's 3 minutes before the hour, and I believe Instagram shuts us off in an hour. So thank you all so much for being here. We got a lot of people on all sides of the platform, on Facebook, on LinkedIn, on YouTube, and on our Instagram pages. Please join me, won't you, every Tuesday afternoon, 4 p.m. Mountain Time. That's 6 p.m. Eastern, or 3 p.m. on the West Coast for Fertility with Fink and Friends. We always try to bring somebody who's going to be smarter and better looking than I am, and who can balance out the fact that maybe I just probably talk a little too much. But so glad to have had you all here today. And just remember, if there's anything that we can do for you on this journey, that's what we're here for. That's what we live for. Our only goal is to help you with your family. So God bless you all. Thank you for being here. We really appreciate it, and see you next week. Kayla, thank you.
Thank you so much.
Good night.
Bye, guys.